video, we're going to be talking about bilirubin and congenital hyperbilirubinemia. So in today's video, we're going to be talking about bilirubin. And as sort of an overview of what we're going to be going through, this is what this video is going to touch on. So we'll start by talking about bilirubin physiology, and then we'll talk about what is the difference exactly between unconjugated and conjugated bilirubin. And we'll conclude the video by talking about the different types of diseases that I'm sure you've seen in your textbooks and in your question banks that come up when you have congenital hyperbilirubinemia. And those diseases are Gilbert syndrome, Crigler-Najjar syndrome, type 1 and type 2, Dubin-Johnson syndrome, and Roeder syndrome. But it's probably asking too much of you to simply memorize different diseases if you don't understand how bilirubin works physiologically. So where I want to start in today's video is let's break down how bilirubin works and what it does and how it moves from one area of the body to the other. Because once you understand that physiology, understanding the diseases that occur congenitally when those different aspects of normal physiology don't work becomes very simple. So let's just start by talking about bilirubin. So we're going to start with a blood vessel. And in the blood vessel, you have heme. Everybody should be familiar with what heme is before starting this lecture. And through two different enzymes, heme will ultimately be converted to bilirubin. And when heme gets converted to bilirubin, we're talking about unconjugated bilirubin. If you want to, we're going to talk about unconjugated versus conjugated in just a bit. But to start, conjugation is a step where there is a chemical alteration of bilirubin where a little molecule gets stuck onto bilirubin, and that occurs downstream. So at this point, we're just talking merely about unconjugated bilirubin. So heme will go to bilirubin through two enzymes. The first enzyme is heme oxygenase, and then the second enzyme is biliverdin reductase. So technically, although it's not pictured on this slide, there is an intermediate product between the first and second arrow, and that's biliverdin. So heme gets converted to biliverdin by heme oxygenase, and then biliverdin gets converted to bilirubin through biliverdin reductase. Now, everything that I've just mentioned, I want you to imagine as happening in the reticuloendothelial system. So everything in that gray box, including the enzymes that we just mentioned, that's all occurring in the reticuloendothelial system. So now we've got bilirubin, and at this point, it's still unconjugated, okay? It has not undergone an alteration which will occur downstream of this in the liver by attaching a molecule to it. Now, the bilirubin is going to flow through the body attached to albumin, and this is really important because if you get a question that puts a patient in some disease state where they have decreased levels of albumin, that can, indirectly affect the availability of circulating unconjugated bilirubin. But at this point, again, bilirubin is just circulating, bound to albumin, and ultimately that bilirubin, which is still unconjugated at this point, will make its way into the liver. Now, let me be clear. Everything that we've talked about so far, which I'm going to show you now by highlighting all the different bilirubin in blue, this is all unconjugated bilirubin because, again, just to really harp on this because it's so important, the bilirubin has not yet been modified in the liver. And it's that chemical modification that's going to occur shortly that's ultimately going to conjugate it. So at this point, we're talking merely about unconjugated bilirubin. So now the bilirubin has arrived in the liver, and now we can finally get to that step where the bilirubin will become conjugated. When you conjugate bilirubin, what you're doing is you're converting unconjugated bilirubin into bilirubin with glucuronic acid attached to it. And the enzyme that does bilirubin conjugation is UDP glucuronyl transferase. Okay, so that is a very important enzyme to memorize because it conjugates unconjugated bilirubin. Now, once bilirubin is conjugated, again, the only difference is that it has glucuronic acid attached to it. And it's that chemical attachment that allows conjugated bilirubin to then move further through this cycle. So once conjugated bilirubin is conjugated, and that is to say that it has glucuronic acid, now it can be secreted into the biliary system. And once that bilirubin gets secreted into the biliary system, it will go through the biliary system and, of course, spill into the intestine. Okay? So now bilirubin, which is conjugated and it has its glucuronic acid attached to it, has made its way to the intestine, where certain modifications are going to occur squarely in the intestine. So the first one is that bilirubin will be converted to urobilinogen, and it's actually the bacteria in the GI tract that makes that conversion possible. Now, urobilinogen takes one of three different steps, okay? And I've shown the three different steps by having three different colored arrows here: the purple arrow, the yellowish arrow, and the brown arrow. The first option shown in purple is that urobilinogen can simply be reabsorbed, and then you can go through this cycle and just keep cycling bilirubin. The other option, shown in yellow, is that urobilinogen can make its way to the kidney and ultimately be converted into urobilin. And it's urobilin that is a yellow pigmented chemical which gives urine its yellow color. The other option is that urobilinogen can continue through the colon and ultimately be converted to stercobilin. And stercobilin is also a pigmented bilirubin derivative that is brown. And that's what gives poop the brown color. So it's really interesting that when you look at somebody's urine or you look at somebody's poop, the reason that urine is yellow and the reason that poop is brown is because of the bilirubin derivative urobilinogen getting converted into either urobilin or stercobilin. And in both of those cases, they are pigmented chemicals. So interestingly, it's bilirubin that gives your poo and your pee its color. So this is everything we've talked about. And just to simplify this, I'm going to now make everything black so you can see this overview. And I want to really delineate what the difference is between the unconjugated and conjugated bilirubin. So your unconjugated steps are shown in blue, and your conjugated steps are shown in red. So this is what happens with bilirubin. And if you understand this pathway and you're understanding how bilirubin comes from heme, flows through the blood, goes to the liver, gets conjugated, and then enters the biliary and ultimately the intestinal system, you should be able to understand where congenital hyperbilirubinemia is coming from. So that's bilirubin, and that's unconjugated versus conjugated. Now let's transition and talk about the high-yield diseases that you'll get tested on test day. This whole group of diseases is referred to as congenital hyperbilirubinemia, which basically means that from the time that you're born, there's something wrong in the physiology that we just talked about that causes you to have too much bilirubin in your system. Congenital hyperbilirubinemias are classically described as either being unconjugated or conjugated, which is to say that if you have an unconjugated congenital hyperbilirubinemia, it's a disease where there's too much unconjugated bilirubin. And likewise, if you have a conjugated congenital hyperbilirubinemia, you have a disease where there's too much conjugated bilirubin. So let's first talk about the unconjugated side. And before we even talk about the diseases, recall from the previous discussion that we just had about the physiology that this is where the unconjugated steps of bilirubin come from. So in order for there to be an unconjugated congenital hyperbilirubinemia, which is to say that there's a disease somewhere in this pathway causing too much unconjugated bilirubin, the problems occur at the areas where you see the two red stars. So either the problem is initially with the heme accumulation, or the problem is with the enzyme UDP glucuronoltransferase. Now, let's briefly talk about heme first, because this is probably the lowest yield part of today's lecture. If you have a disease where you undergo way too much hemolysis, you're going to have the generation of a lot of heme, because that's a breakdown product from the red blood cell. And if there's all this heme coming into the system, and all of that heme is going to be converted into bilirubin, well then of course you're going to have too much unconjugated bilirubin, because you're converting heme, which is just accumulating in these massive quantities because your red blood cells are being hemolyzed. And then you've got all that unconjugated bilirubin that the body just doesn't know what to do with it. So that can cause an elevation in unconjugated bilirubin. The other problem is with the enzyme UDP glucuronoltransferase, because if you either have a deficiency of or a complete knockout of that enzyme, as you can see on this slide, you're not going to be able to convert the unconjugated bilirubin in the liver to the conjugated form, because the enzyme that's responsible for that reaction is not working properly. And that is the highest yield part of the unconjugated hyperbilirubinemia. So let's talk about the three diseases that are unconjugated. So you've got Gilbert syndrome and Crigler-Najjar syndrome type 1 and Crigler-Najjar syndrome type 2. Let's just go through them one at a time. So we'll start with Gilbert syndrome. So the problem here is that you have a knockout of the gene that is UGT1A1. And that gene is responsible for basically coding for that enzyme. And if you have a problem with the gene that codes for the enzyme, then you have decreased or dysfunctional levels of UDP glucuronyltransferase, which means you have increased levels of unconjugated, sometimes referred to as indirect bilirubin. So remember, here's the slide that we've seen already. So if you take out the gene that codes for the enzyme UDP glucuronyltransferase, then that enzyme is gone, which means you have increased levels of the unconjugated bilirubin because it cannot be conjugated into the form of bilirubin that gets the glucuronic acid attached to it. So that's the problem with Gilbert syndrome. Now, how do you remember this, right? That's quite a bit of information. Well, what I say is UGT, which reminds me of a few things. One, UGT for unconjugated Gilbert. Okay, so the U, the G, and the T. Reminds me that Gilbert syndrome is an unconjugated elevation of bilirubin. UGT also is directly taken from the name of the gene knockout, and UGT reminds me of UDP glucuronyltransferase. So Gilbert is UGT, and there's only one of these diseases with a G in the name, and that's Gilbert. So pretty easy to remember, that's Gilbert syndrome. The other two unconjugated congenital hyperbilirubinemia are the two different types of Crigler-Najjar syndrome. And I think for the sake of studying, it's probably best if we just include this discussion on the same slide so that you can see the differences between type 1 and type 2. So for type 1 Crigler-Najjar, the problem is that you have a complete dysfunction of UDP glucuronyltransferase, so a knockout basically. The enzyme just simply isn't there. So you're going to have very elevated levels of indirect or unconjugated bilirubin. The problem with type 2 Crigler-Najjar is that you don't fully knock out the enzyme, but you have a deficiency of the enzyme, okay? So the enzyme activity is decreased, but it's still there a little bit. And because of that, you're going to get an increase in your unconjugated or indirect bilirubin, but it's not going to be as high of a level that you see in type 1 Crigler-Najjar, where you simply have no enzyme whatsoever. Okay, so let's go back to this slide. Remember, if you knock out that enzyme, UDP glucuronyltransferase, then you have increasing levels of unconjugated bilirubin. If you only have a little deficiency of that enzyme, you're still going to get an elevation of unconjugated bilirubin, but it's not going to be as much. So that's type 1 versus type 2. Now, something that's really important to understand is that because you have massively increased levels of indirect bilirubin in type 1, these patients are prone to getting kernicterus, whereas patients who have type 2 Crigler-Najjar are not going to get kernicterus. And if you've never heard about kernicterus before, basically it's when all of this bilirubin accumulates in the bloodstream and that goes up to the brain and becomes neurotoxic. So you might see something like this, a CAT scan of the brain, which shows a bilirubin encephalopathy with neurotoxic lesions in the basal ganglia. So bilirubin is neurotoxic. If it goes up to the brain, it's going to cause lots of issues and it can be fatal very quickly. So these patients who have Crigler-Najjar syndrome type 1 are not going to do well. The other thing that you need to know is that type 1 Crigler-Najjar syndrome will not respond to phenobarbital, but type 2 Crigler-Najjar syndrome will. Basically, phenobarbital is a barbiturate medication that can be given to decrease levels of unconjugated bilirubin, but only patients with type 2 Crigler-Najjar syndrome will have any response to that. So on test day, if you're taking your test and you see a question and they give you a patient who was treated with phenobarbital and that bilirubin level came down, that tells you immediately that they can't have type 1 Crigler-Najjar syndrome because those patients simply don't respond. My mnemonic for remembering that patients with type 2 Crigler-Najjar syndrome respond to phenobarbital is I say phenobarbital. So instead of phenobarbital, I say phenobarbital, which reminds me that phenobarb, patients with type 2 respond to it. So those are your Crigler-Najjar syndrome. So at this point in the lecture, We've talked about bilirubin physiology and how bilirubin works in the body normally. We've talked about the difference between unconjugated bilirubin without the glucuronic acid and conjugated bilirubin with the glucuronic acid, what those differences are. And we just had a discussion about the 3 different types of unconjugated hyperbilirubinemia. Now let's wrap up by switching gears and talking about the other side of this chart, the conjugated congenital hyperbilirubinemia. So remember that when we talked about the difference between unconjugated and conjugated, this is the slide that we were on. And the problem in conjugated hyperbilirubinemia is where the pink star is located. So it's a problem with getting the conjugated bilirubin basically out of the liver and into the biliary system. Because as you might imagine, if you have difficulty moving that conjugated bilirubin around, you're going to have increased levels of it. The 2 diseases where that happens are Dubin-Johnson syndrome and Rotor syndrome. So these are the 2 that you need to know on the conjugated side. Let's start by talking about Dubin-Johnson syndrome. So the pathophysiology here is that the MRP2 protein is dysfunctional. And the MRP2 protein is basically responsible for the hepatic excretion of conjugated bilirubin. So if that protein is missing or is not working, then you're not going to be able to get conjugated bilirubin out of the liver. And when that happens, as you see on this slide, where the pink star is located, if that bilirubin with the glucuronic acid attached to it can't leave the liver, then you have increased levels of conjugated bilirubin, as you see on this slide. So you knock out the ability to shuttle that conjugated bilirubin out of the liver, and you get increased levels of the conjugated bilirubin that has the glucuronic acid attached to it. Now, interestingly, in Dubin-Johnson syndrome, one of the very high yield features is that patients will have a black liver. They will have a black liver, and that's due to the accumulation of a pigment in the liver due to the inability to get that conjugated bilirubin out of the liver. So if you see this picture on your exam, they're talking about Dubin-Johnson syndrome. The other really high yield bit of information that you need to know is that in these patients with Dubin-Johnson syndrome, oral contraception is actually contraindicated. The reason for that is that the MRP2 protein, which is obviously dysfunctional in Dubin-Johnson syndrome, well, that protein is also involved in the metabolism of estrogen and progesterone. So if you give somebody oral contraception and they can't metabolize properly the estrogen or the progesterone in the oral contraception, they can become toxic quite quickly. So that's very high yield. Do not give these patients oral contraception because oral contraception also relies on the MRP2 protein. So that's Dubin-Johnson syndrome. And Rotor syndrome is pretty similar. Rotor syndrome, the problem is that you have 2 different polypeptides that are defective. You have the OATP1B1 and OATP1B3. They're both defective. Those are similarly responsible for the uptake and excretion of conjugated bilirubin from the liver. So just like Dubin-Johnson syndrome, if you have a problem getting that conjugated bilirubin out of the liver because you can't excrete it, you're going to have an elevation in the conjugated bilirubin because since it can't get out, it's just sitting around. Really, the way to differentiate Rotor syndrome from Dubin-Johnson syndrome, at least clinically, is that there's no black liver in Rotor syndrome. But in Dubin-Johnson syndrome, you do see that black liver. So for some reason, test writers love to go after this. They'll give you all the lab printouts that will suggest to you that conjugated bilirubin is elevated. And in your head, you're now generating a differential. This is either Dubin-Johnson syndrome or Rotor syndrome. And if they don't tell you anything about the pathophysiology, which is to say they don't tell you if it's OATP1 or MRP2, whatever, the only difference is that one has a black liver, grossly, when you look at the liver, and one doesn't. So test writers will go after that. Just like in Dubin-Johnson syndrome, in Rotor syndrome, oral contraception is contraindicated, okay? Because OATP1B1 and OATP1B3 are also involved in the metabolism of estrogen and progesterone. So how do you remember this? Well, I say Rotor syndrome, and I replace the O with oat, Rotor syndrome. And that reminds me of OAT for OATP1B1 and OATP1B3. That's Rotor syndrome. So again, very high yield. Dubin-Johnson and Rotor syndrome both cause increased levels of conjugated bilirubin, but only Dubin-Johnson syndrome has the black liver. Test writers go after this all the freaking time. You have to memorize this. Now I know what you're thinking. Dirty. If I have to memorize this, if this is as high yield as you claim it to be, what's your mnemonic? Well, when I think of Dubin Johnson, I think of Dwayne Johnson. Dwayne Johnson, arguably the greatest wrestler of all time, Dwayne "The Rock" Johnson, is part black. And that reminds me that in Dubin Johnson, or in Dwayne Johnson, you get a black liver. Finally, The Rock has come back to dirty medicine. That's it, guys. I hope that you enjoyed this video. I hope that now you have a better understanding of how bilirubin works, what the difference is between conjugated and unconjugated, and what those diseases actually mean. I think that I did a good job of breaking this down, but if you have any further questions, do not hesitate to put a comment on this video and support the channel. Love you. Good luck.